developed for non-invasive treatment of solid tumors. How is it applied in the case of ventricular tachycardia? Is the tissue in the heart muscle scarred or removed?
So first thing I'll say is that this acronym is what SBT stands for. And that is a commonly used technology for the non-invasive treatment of solid tumors. In our department in radiation oncology, we do this for hundreds of patients every month. And we use it for a range of tumors in the body. We can use stereotactic radiation therapy to deliver high precision radiation treatment. And it's also called stereotactic radiosurgery. So it's like doing surgery, but without the invasive component. And it can be used for spinal tumors. It can be used for brain tumors. It can be used for lung tumors. It can be used for pancreatic cancer. It can be used for prostate tumors and for liver tumors. So a variety of tumors in the body, it's increasingly being utilized. And that's because it's found to be a more effective form of radiation therapy, given that our technology has allowed us to give these high doses of radiation in fewer treatments. For lung, which is the most similar treatment to this type of treatment that this patient received, these types of tumors, we do hundreds of, in our department, and they can be done in anywhere from 1 to 5 treatments most common. In this case, in a patient who has ventricular tachycardia, non-malignancy, it's different. We're using it to stop really electrical misfiring of a certain part of the heart, which is causing the arrhythmia in the patient.
Got it. And so you did mention that this has been widely used. I am going to jump to another question just because it's kind of like in the same line. How common would we be able to say that this procedure is then on a national or international level? Specifically, the one that was done.
Exactly. So although we do stereotactic radiation in our department every single day, I myself do 8-10 cases in a day, and we do this very commonly across our department. Doing stereotactic radiation therapy for an arrhythmia is done very infrequently in the world, very rarely, because you need to have a good cardiac team, a good cardiac imaging team, and then you have to have the radiation therapy team. And despite heart disease and cancer being the top 2 killers in the United States or in the world right now, these are 2 teams that don't typically interact together. And this is not a common indication for radiation treatment, given that it's a non-malignant indication. So this really requires a synergy among 3 services, and really is led by from the cardiology standpoint, for patient selection, for delineation of where we should treat, and then to work with the radiation team to really be able to target that area with radiation. So it's being done in most places in a research mode, and then for select patients who would need this, off a study is being performed. But that's very seldom. If you had to ask me to guess, I don't know if we could put that in writing. I think it's a very few number of cases that are done across the entire country or world.
No, that's great to know. And I mean, we can obviously do a little bit more digging there, but wanted to see if where else this has been done. But wanted to get your point of view there. So directly to the condition, how common and serious?
I think that if you look at,
No, go for it.
I was going to say, if you look at in the world, in the published literature, I think you'd probably find 30, 40 patients maybe in the entire world that have ever had this treatment. So.
Okay, this is helpful. Thank you. Okay, so talking about the condition, how common and how serious is ventricular tachycardia, and what are the common causes?
Yeah, I'll take this one. So, ventricular tachycardia is actually is a manifestation of sudden cardiac death. When we talk about sudden cardiac death, that's what ventricular tachycardia, ventricular fibrillation is, and it's actually the number 1 cause of death in this country. So ventricular tachycardia is very common. The number 1 cause of ventricular tachycardia is going to be underlying heart disease. So patients with a cardiomyopathy or a weak heart, or patients with underlying coronary artery disease. And the treatment for ventricular tachycardia is not just ablation procedure. It's actually a multi-pronged approach. So we have defibrillators to treat patients for defibrillators. We have for ventricular tachycardia. We have medications to try to prevent ventricular tachycardia. And we have multiple specialists, general cardiologists, heart failure physicians, as well as electrophysiologists, who use a multidisciplinary approach in order to treat ventricular tachycardia. And despite this, ventricular tachycardia still remains the number one cause of death in this country. So it's quite common, especially in patients with structural heart disease.
You're on mute, Gabby. The audio and totally lost you guys. Okay, perfect. Thank you so much. And to that end, you mentioned there's different ways, of course, of treating it. We do have here, what are some alternative procedures for the ventricular tachycardia that we could potentially, I would say like probably the top alternative.
Sure. Right. Yeah, so, I think the standard of care for ventricular tachycardia at this time remains medical therapy. Okay, so we always try medical therapy and see if medical therapy can suppress and treat the patient's ventricular arrhythmias. The problem with medications is, one, they have very limited efficacy, so rarely do we achieve adequate control of patients' ventricular arrhythmias. And number two is medications, especially the ones for ventricular tachycardia, will have a list of long-term toxicities. So patients just can't remain on these medications for a year on end because they will establish some associated toxicities with the medication. When you go into the procedural aspect of ventricular tachycardia, that's where we go into the catheter-based ablation. So the catheter-based ablation is actually where we bring in a patient into the electrophysiology lab. We put in catheters from their groin into their hearts, and we start to map the ventricular tachycardia from the inside of the heart, and occasionally and frequently from the outside of the heart as well. Okay, so we have to remember that the heart itself, the heart muscle, is a three-dimensional structure. It has an inside portion, it has an outside portion, and then it has the meat in the middle. And so our catheters tend to be pretty good at ablating areas inside the heart, tends to be pretty good at ablating areas outside of the heart. But there's a lot of areas that we have difficulty getting to, especially if it's within the heart muscle itself. So not on the inside or the outside, but kind of in the middle. And so that's what limits the efficacy of our standard therapies now, which include what we call a catheter-based ventricular tachycardia ablation. Those procedures are also quite complex. So if we compare them to the procedure we did, those patients are frequently under general anesthesia, occasionally under modified anesthesia care. Procedures take hours on end in order to be successful. And patients frequently require a prolonged ICU stay because their underlying heart disease is so severe that after the procedure, there's some period of decompensation before they actually get better. So those are the true limitations, and that's why as an electrophysiology community, we knew that we had to have a better approach, a way to increase the long-term efficacy, decrease the periprocedural complications, and really to get to areas of the heart that are really inaccessible to us right now.
Thank you. And now talking about the patients specifically, right? You mentioned that there hasn't been many cases, and even in the world that where this procedure has been done. What were the factors that led your team to perform this in this specific patient?
Sure. Yeah, I think that's where we get into, why are we exploring, stereotactic radioablation and for this patient? And I think we needed to match the needs of the patient, which we couldn't get with a standard catheter ablation. I think one is that we felt that the patient was too sick. If we look at the overall, clinical picture of the patient, he had recently had a pretty prolonged surgery that took about 10 hours to do, an open heart surgery, which during that procedure, he also had an attempt at VT ablation. So we gave one attempt at VT ablation in our standard approach at the same time that he was also having open heart surgery. We felt that the VT may be coming from an area that was on the outside of the heart, And because he had had 2 previous open heart surgeries, accessing the area outside of the heart would have been extremely difficult. And we had a patient we had already delivered 1 therapy of an ablation and had been unsuccessful. And so I think the unmet needs on this patient were too sick for a redo ablation, an attempt at ablation which had already been unsuccessful, and really felt the arrhythmia was coming from an area that we thought we would have a very difficult time accessing with our standard ablation and catheters.
Great, and I mean, I know we have it here in the questions. I want to make sure that that's okay with you guys. Is it possible to know the gender and age of the patient? I know we just talked about the condition pre-procedure, but how he or she is doing now?
He's doing fantastic. It's a male. He's 76, I want to say. I don't have my computer open, but kind of late 70s. He's doing fantastic. I just talked to him last week, and I think Dr. Cochessa talks to him every single day, or at least his office does. And he's doing great. I mean, immediately from the day of the procedure, again, if we look at our standard ablation, catheter ablation, I know this patient would have been in the ICU, would have had probably a prolonged ICU stay. The day we did the ablation, he literally got off the table. We walked him to a room, talked to him for about 20 minutes, make sure he was okay, and he went home and had dinner. And since then, he's just continued to feel better and better, has not had any side effects to treatment whatsoever. And we're hopeful that 1 month after the procedure, we can start to withdraw some of those agents, some of what we call those anti-arrhythmic medications, to get rid of some of those associated toxicities, which he has been having, but we've had to continue because if not, he'd have recurrent VT, which is certainly a dangerous and life-threatening arrhythmia. So we're keeping our fingers crossed, and we're hoping that when I see him, should be just a few weeks away now, we can start pulling back some of these medications, and I really think that's going to significantly increase his lifestyle and his quality of life for sure.
That's
Just
wonderful.
to jump in really quick, Gabby, one thing to know, we have photos from the day of his procedure that Dr. sent over, so we have a couple of visuals. And if he's coming in, Dr. Pasquale, I'll check in with you on when his follow-up date is. Perhaps it would be nice to get maybe some follow-up photos of whenever he comes in for that visit. If we think that we need it, Gabby, we'll check in before. Do you think it's in a month from now, Lisa?
Should be in a couple of weeks because I'm going to see him a month after the treatment. So, yeah, we can figure that out.
Yeah, great. Whatever you may have that can support the outreach efforts, that would be wonderful.
Okay.
Okay, I did jump one question. It was our second question. Can you talk a little bit about the real-time imaging that was used during the procedure?
Sure. So before the procedure, the patient actually underwent a cardiac-gated CT scan in MCVI, then had a respiratory-gated CT scan in MCI, and then at the time of treatment, we do what's called a cone beam CT, which is a CT scan on the machine. We then delivered 2 arcs of radiation and then did another CT scan afterwards to ensure that there was no motion between that entire delivery as a verification, which was perfectly on. And then we did another CT scan before delivering the 3rd arc or beam of radiation. All of these verification scans lined up to his original simulation scan done in radiation oncology.
Thank you. Okay, taking into consideration that we can say you both have been one of the very few physicians that have been doing this, right? This type of procedure for this type of condition. What are any learnings or recommendations that you may have for peers who might be looking at performing this procedure as well for their patients?
You want to take this one? I guess
Okay,
we'll probably both have different answers here. But, I think the first thing I would say is that really this really requires a multidisciplinary approach. If we look at who was involved, it was electrophysiology, it was our advanced heart failure team, it was our general cardiologist, it was our cardiac imaging specialist, and the MVP, Dr. Cocheta, there with the radiation oncologist. So really it took 5 specialists to really come up with the treatment plan for this patient. So it's not just, we have a patient, we want to do SBRT, send him to the radiation oncologist, let them take care of it. It was really sitting down with all 5 specialists, reviewing the clinical case scenario, reviewing all images, and assuring that this was an adequate patient, that we felt we can do a successful procedure, understanding the limitations and the success rates and the reasons to do radioablation, and really targeting that approach. I met with Dr. Cocheta multiple nights prior to the procedure, making sure that we were understanding the images. As an electrophysiologist, a specialist, and even as a cardiac imager, we look at scans very differently than the radiation oncologists do. And so it's really trying to get on the same page as the radiation oncologist and saying, okay, this is the area we have to target. So I think we have 2 different specialists. We can do a pretty good job in assessing which areas we have to target based on the patient itself, the type of ventricular arrhythmias he's having, and where the heart disease is. But when it turns to how do we treat that area, that's really where the radiation oncologists come in. And so it's understanding both target and treatment. And it was really for me doing like a crash course fellowship in reviewing CT scans in ways I had never had to look at them again. And I think that's also one of the reasons why, WashU, and it was so important to meet with, our colleagues at Washington University. They had a lot of experience with this, and just bouncing the ideas, giving them a case presentation, assuring we were on the same page with them was so very helpful.
Yeah, I agree completely. So I think, as I mentioned, probably 30 or 40 patients have been treated in the world. Of that, probably 25 patients or more have been treated at one facility. So it's probably 5 or fewer teams, maybe 10 teams total in the world, probably 5 or fewer in the US, that have come together from cardiology and radiation oncology to be able to do this type of treatment. So before venturing this, we met with the WashU team. We had the entire cardiology team present everything about the patient, go through the images. We went through our plan with radiation. And then at each step of the way, we actually worked with the WashU team to get their blessing to ensure that we were doing this appropriately and that we were doing it using the way that they've had success in the patients that they have treated. And we wanted to basically be able to mirror that with regards to our development of a program here. But again, it takes a lot of coordination from both teams that I said that don't typically interact, other than the cafeteria, I would say.
No, that's great. Thank you so much. And our last question would really tie back to this and kind of looking into the future, right? When we think of the future of this procedure, there is still a lot of research that needs to be done, understanding that there haven't been that many teams that have been involved in this. Is MCVI planning on doing any type of research or any type of clinical trials to continue advancing or improving this procedure?
So right now, because of the way that this research is done, it requires an IND by the FDA. The FDA has granted it to WashU, who has been doing most of them, and Emory University, which was also doing them at that time. I think other facilities are able to treat patients off trial, given that they have a published phase 1, phase 2 clinical trial that was done at WashU that has been published in the literature already. So from a clinical standpoint, if a patient can derive clinical benefit from this treatment, then the cardiology team, Dr. Pasquale and the entire cardiology team, will evaluate any future potential patients to ensure that they would be a candidate for it. And then we would work to develop a radiation plan together, just like we did for this first patient, for any patient going forward. So from our standpoint and our institution, this would be done not in a research mode, but for patients who would benefit clinically from the treatment.
Great.
I have 2 really quick questions just for clarity. The location was at Miami Cancer Institute, correct, of the procedure? I originally thought it was at MCVI Gallery, but what location within MCI was the procedure take place?
The procedure took place on Vault 4. in radiation oncology and MCI, which is a machine that we use commonly for stereotactic radiation. Dr. Pasquale and the cardiology team was actually present for the entire treatment, though. We had to bring them over to MCI.
Got it.
They
And
almost
then,
didn't allow me through security that day.
That would have been bad.
So I know these are the questions that we had, but I want to be mindful, John, if you have any other questions that may have arisen through the conversation that we had today, perhaps here, George.
Just a couple of brief questions. I think, Dr. Pasquale, you mentioned that this patient's history where he's had 2 open heart surgeries, I believe you said.
Exactly right.
And did he have previously a catheter ablation, or was it a surgical ablation? I believe you.
It was a surgical ablation with a catheter ablation at the same time, so it was a combined approach at that time.
And that did not obviously give the results you were looking for. And
it did, and yet he did well for approximately 3 months after that procedure, and unfortunately, after 3 months, his what we call VT burden, meaning the number of episodes, actually increased quite a bit. So he had 2 hospitalizations for what we call incessant VT. He was in ventricular tachycardia for greater than 24 hours at a time, each time, incessantly, despite the previous attempts at ablation.
And the major symptoms he was experiencing, can you just quickly say? I mean, I assume
Of course,
related to the VT.
Definitely, yeah. So lightheadedness, dizziness, and recurrent episodes of passing out were his main symptoms. And he knew exactly when he went into it. I mean, he would call me, and, there's different types of ventricular tachycardia where your heart rate can either be 200 beats per minute and you're passing out and getting shocked by your defibrillator. Because he had an ablation in the past, they tend to present with more stable ventricular tachycardia, meaning that they could be awake during their episodes. And so his ventricular tachycardia was actually about 120, 130 beats per minute. So imagine it's somebody like doing mild exercise. So he was awake. When he was in ventricular tachycardia, but just felt very poorly and would immediately go into heart failure. So he would call me and say, I'm sure I'm back in VT. My heart rate is 120 beats per minute. We'd bring him into the emergency room and have to optimize him then.
That's amazing. And you mentioned the Washington University team. I assume they were the first in the U.S. or am I correct?
I want to say they were the first in the world. Yeah.
Wow. Okay. Yeah. I mean, I saw.
I think so. Technically, from a single patient standpoint, so CyberKnife and the CyberHeart system in Stanford, I think, treated a patient. Boston had treated a patient, but the first to do a prospective, study in 5 patients was the WashU group that led to a New England Journal paper.
Okay. Yeah, because I did see an article from 2017 from Washington University site, the website, where they were talking about this procedure. It's like 4 years ago almost. But I mean, I find it intriguing that that you reached out to them and you had presentations and I mean that shows great collaboration with the first team to one of the first to do this. I think that's it. Is there anything else important about this procedure in particular that we haven't discussed, doctors? I think we've covered pretty much everything.
Yeah, I think the things to emphasize is, really the recovery is just significantly different. I would say the prep work ahead of time is there's more to it, but the recovery of the patients is significantly improved as compared to our standard catheter ablation. There's still many unknowns. We still have to figure out the long-term efficacy, consequences, and the ideal doses of treatment. But we're very optimistic about this option for our patients with ventricular tachycardia.
That's remarkable. Congratulations to both of you. Thank you very much. We look forward to follow up. With the patient. That'd be great.
Yeah, so in terms of next steps, we're going to put some material together. We'll send it back over to review for accuracy. We'll reach out with any next step, any media that we'll probably go back on